Perfusion pressure in patients with acute severe head trauma is 50 millimeters, 60 millimeters, 70, I don't know, and I don't care. So we can go ahead and collect the answers, please. Okay, well, 43% of you are with the current guidelines. If I'd asked you 10 years ago, it would have been 70. If I ask you 10 years from now, it won't be any of these numbers. It will be whatever produces adequate brain oxygenation. But right now we're still using this, and 60 appears to give you the best balance between cerebral oxygenation and the systemic effects of inducing increases in volume and flow to get there. So 60 is what's recommended in the brain trauma guidelines, although there is some hedging already in some of their statements. All right, so how do we measure intracranial pressure? The gold standard has always been a ventriculostomy catheter. It's also useful for treatment. You can withdraw some CSF. Once the ventricle swells and has really abutted against the little holes in the catheter, though, it may stop working. Epidural transducers sound like a great idea, less risk of hemorrhage, less risk of infection, and unfortunately, no decent information. They're not worth using. A subarachnoid bolt was a hole that was put through the skull. You made an incision in the dura, screwed a bolt in there, and then had a fluid-filled column in continuity with the subarachnoid space. That worked great until the brain swelled and plugged up the hole. Okay, and that happened, then you had to squirt fluid in there, which is the opposite of what you want to do because you're going to raise the intracranial pressure even with slight bits of fluid. Or you could stick a probe in there and irritate the brain, I suppose. The parenchymal monitors are what we typically do when we don't have a ventriculostomy. There are different ways of putting them in. They work about the same from a functional standpoint. They are pretty decent for about 5 days, after which you start to get gliosis around the tip of the catheter and the pressures deviate from what you measure with a coincident ventriculostomy. So typically it'll be either the parenchymal monitor or the ventriculostomy. When you're going to measure cerebral perfusion pressure, you have to pay attention to where the arterial transducer is. For every other thing I know about, we put the arterial transducer in the mid-axillary line at the so-called phlebostatic axis, which is fine if you want to know what the blood pressure at the heart is, but I don't give a damn what the pressure at the heart is. I want to know the arterial pressure that the brain is seeing. And therefore, I zero and tape the transducer next to the ear, and when the head goes up, the transducer goes up with it. It doesn't matter what the systemic arterial pressure is. What matters is the pressure that the brain is seeing. So the arterial transducer needs to be at the ear, not at the chest level. This is not a matter of opinion, it's a matter of physics. Now, if you don't like me, you can go back and look at the original papers discussing cerebral perfusion pressure, where they specifically say that the transducer is zeroed at the ear. You can also try to measure oxygenation. Jugular venous blood is commonly sampled. You put an IJ in, but you put it up the other direction. You get an X-ray, show that you're in the jugular bulb. This is useful information if it's low. So if the saturation is low or the oxygen content is low, that's bad. It means there's inadequate perfusion or oxygenation. The lactate in the venous blood should be lower than the lactate in the arterial blood. The brain is normally a lactate extractor. If the lactate in the venous blood goes up, that means now that lactate's being produced in the brain, and that's bad. The problem with this technique is that it samples a huge amount of brain. And as opposed to what you might think that the left jugular vein would drain the left side of the brain, it doesn't work that way. The right jugular brain tends to drain the superficial parts of both hemispheres, and the left tends to drain the deep. And if you put bilateral catheters in, you get widely different saturations on the two sides. So I don't bother with them anymore, but you may have to understand how they work. Direct cortical oxygen sensing is what we typically use now. The only one on the market is called Lycox. You put it in and you get great measurement of the extracellular fluid oxygen content for a few cubic millimeters around the tip of the catheter. So obviously where you put the catheter is important. You don't want to put it in dead brain. And we're still looking at what the best place to put it is, but this gives us the most useful information we've had so far. We'll come back to that in just a moment. If we look at therapeutic approaches to intracranial hypertension, we can go back to Cushing, who thought, well, the brain's getting hung up on the tentorium. If I just make a cut in the tentorium, then there won't be a problem. Well, all that did was grease the path out the foramen magnum, so that didn't work too well. Osmotic diuretics were introduced in 1923. There were 2 randomized trials of hypothermia going back to 1955, and 35 years later we're still trying to sort this out. Hyperventilation was noticed to lower ICP in 1957. Ventricular drainage was introduced in 60. And this is also the point at which we have continuous monitoring. Before that, you had to do a lumbar puncture or stick a needle in the ventricle every time you wanted to know the pressure. Steroids for tumors were introduced in 61. Decompressive craniectomy, either the bifrontal Schellberg procedure or the lateral Ransohoff procedures, both in 1971. High-dose barbiturates in 1973, and now I'll show you all the advances since 1973. Now that we've seen them, we'll move on. Well, what do we know about ICP? Well, if the ICP remains above 20 in patients with acute head injury, that's associated with a poor outcome. That's all we really honestly know about it, that being high is bad. There is the Monroe-Kelly hypothesis that the skull has a fixed volume, but you can overcome that by taking the skull apart. If there's a mass lesion in the brain that can come out, it ought to come out to lower the ICP. And although there can be circumstances in which blood flow is increased, for practical purposes, your patient is never hyperemic. Right? That the ICP is up, it means there's swelling, and the swelling is either a cause or a consequence of ischemia. So all that we're going to worry about today is ischemia, not the rare patient who actually does have hyperemia. Cerebral perfusion pressure is the difference between the mean arterial pressure and the ICP. We already talked about how to measure the mean arterial pressure. There are 2 schools of management. One says that we should keep the CPP adequate regardless of the ICP. That's the Rossner theory. Or there's the Lund protocol, which says we should lower the mean arterial pressure so there's less edema production. They both claim better outcome compared to historical controls. Now you'd think, gee, these are completely opposites. But if you read the papers that they come from, Rossner says this, but then the first thing he does is put in a ventriculostomy with a pop-off at 20. So he is, in fact, controlling ICP. He's just not admitting it. And the Lund people say, but we did try to keep the cerebral perfusion pressure at 60 if we could. So when they actually do this, there's not as much of a difference. There's a substantial group of head trauma patients who are ischemic in the first 24 hours. And if you look in the most recent guidelines, you'll see that they finally admit this and say that it's important to avoid worsening the ischemia, especially in the first 24 hours. This led to a movement against the use of hypertension, and that's not really supported by the available data to the extent that some of my colleagues like to push it. What do we do know? Here's another absolute fact. Steroids kill. Right? If you have somebody with acute head trauma, there is no circumstance in which steroids should be given. Right? The one exception people try to bring up is if you have traumatic optic neuropathy, you might benefit from steroids, but that's never been tested in this population. This was a study that never should have been done. There was already plenty of evidence before it started that steroids were deleterious in head trauma, but now we killed an extra 600 patients in order to prove it. It doesn't matter what the nature of your injury is, how quickly the steroids were started after the injury, whether you're looking at death or severe disability as an outcome, there's nothing in which steroids look useful in this setting. So if you don't remember anything else I said today, remember that. Well, if you don't die from the immediate problems, what else kills you or at least impairs your recovery? The main thing we look at now is diffuse axonal injury, which is not what the radiologist calls shearing injury. That when the radiologist shows you areas where there's either blood visible at the gray-white junction on the CT or you do an MR and you see areas of increased gradient echo signal suggesting that there is blood leaking out of vessels, those are actual physical disruptions of the capillaries. But this is an active process that's triggered at the injury that in humans takes about 24 hours to complete. You can have it without any radiographic problem except now the way we diagnose it is to do diffusion tensor imaging, and you can see how badly damaged these white matter tracts are. It is frequently seen in areas where there is shear injury, and it's a major cause of long-term disability. Just as an aside, you'll see a lot of posters around that say, a picture of the skull, and they say that this is the Monroe-Kelly doctrine. Well, just to remember, this is the Monroe doctrine. Keep foreigners out of the Caribbean. The Monroe-Kelly hypothesis was that the skull had a fixed volume, and we now get past that by doing a craniectomy. Got a few duplicated slides here. This was what Mike Rossner used as the reason to say cerebral perfusion is what we should look at. There's this area, the so-called autoregulatory zone, where over a range of mean arterial pressures, cerebral blood flow remains constant. This is a great drawing, but if you look at the data from which it came, there's a sort of an S-shaped cloud of values here. It's not really that this is so tight. The important thing to remember, though, is what's happening as you raise the pressure. All right, so that at this end, where the mean arterial pressure is about 60, the sphincters on arterioles are maximally dilated. And if the pressure falls any further, then flow has to fall. There's no way to augment it. As you move from left to right, the blood vessels are constricting. All right, so when you get to this point, now they're maximally constricted, and if the pressure gets higher, the sphincters fail and perfusion goes up again. This is hypertensive encephalopathy. This is also preeclampsia or eclampsia. In this range, though, there should be a change in intracranial pressure as the blood volume is falling. And that's what Rossner was trying to exploit. That as you raise the blood pressure, cerebral perfusion improves, and in fact the ICP should go down because the vessels are constricting. This is a test of that hypothesis. This is a study from Australia looking at head-injured patients. In the 40 patients they studied, 19 of them had the expected change in cerebral vascular tone, but just over half of them failed to autoregulate. They were pressure passive. When their blood pressure went up, their cerebral blood flow went up. Now, as it happens, this is an attempt to draw that out. Normally, those blood vessels are constricting, the ICP should fall. But if you're pressure passive, the blood vessels will just dilate. The ICP goes up, but they're not in parallel, so that as you raise the mean arterial pressure, it's rising faster than the ICP. So you can still improve cerebral perfusion, but you shouldn't be concerned because the ICP has gone up a little bit. That's an expected phenomenon in people like this, over half of whom have had failure of autoregulation. Well, those patients were in Australia. Their heads are upside down. Maybe it works differently up here. But in California, it worked exactly the same way. In fact, almost the same percentage of people had failure of pressure autoregulation when it was tested. So autoregulation is great for all of you, but when you need it, like after a head injury or after a stroke or an intracerebral hemorrhage, it's likely to fail. Now you might wonder why there's a paper here on the renal effects of norepinephrine. Buried in it is some very interesting information. Basically, in these patients, as you raised their blood pressure, you actually had an improvement in cerebral perfusion. So giving pressors may, in fact, result in an improvement in blood vessel tone. And this is another study that did the same thing. I'll skip this. All right, so what happens if we try to optimize brain oxygenation as opposed to playing around with the pressure? So we put in one of these oxygen probes, and we may, in fact, let the CO2 come up a little bit so that there's better perfusion. We may increase cardiac output with dobutamine. We may transfuse the patient to increase oxygen carrying capacity. This was a before and after study done at the University of Pennsylvania looking at the outcome of patients with severe traumatic brain injury. And this is looking at the mortality when they just used the ICP, CPP theory versus measuring brain oxygen and trying to optimize it. They cut the mortality almost in half. If you look at the short-term outcome of the patients, of the survivors, a chunk of the ones in the ICP management just went off to nursing homes. Everybody in the group with brain oxygen monitoring either went to rehab or was able to go straight home. Well, when the people at Penn first told me about this years ago, I thought, this can't be right. But I have to say now, after doing brain oxygen monitoring for about 10 years, I think this is absolutely the best thing we can do. There is now a proposal before the NIH for a randomized trial in head trauma patients to compare one form of management to this brain oxygen monitoring, and I think it's a great proposal, but I'd have trouble participating because I really don't have equipoise anymore. Well, what does hyperventilation do? You're trying to produce vasoconstriction by raising the pH. It's common to say that hyperventilation stops working, just like this pointer did. But let's see if this one works. No. The point is here that the hyperventilation has not stopped working in the sense that pH is still controlling the caliber of the vessels. However, whatever was causing the brain to swell is still there. So you take out volume by hyperventilating and you replace it with edema or pus or whatever's in there. The choroid plexus is also working against you. It's trying to lower the pH that you've raised by exporting bicarbonate. This works in over about 6 hours in normals. It takes longer in people with head injury. Plus, as you try to increase the hyperventilation, you've either got to increase the tidal volume or increase the respiratory rate. Either of those is going to increase intrathoracic pressure, which will eventually get high enough to impair jugular venous return, and that's going to raise intracranial pressure. So there are limits to what you can do with hyperventilation. I suppose you could try a novel lung and extract the CO2 directly to affect the pH. The way that you know the hyperventilation is still working is that if you stop doing it, the ICP will go through the roof. So you can't just say, well, we're not getting a good effect anymore. We'll let the pH go back to 7.4. It's not going to work well. I included this really for historical reasons. Suffice it to say that the Muselar study is the one that was stopped early because it looked like the hyperventilated patients had worse outcomes. At 1 year, there was no difference. And we really just say hyperventilation is something you can consider in a very short term and while you're waiting for something else to work. So mannitol, hypertonic saline, decompressive craniectomy, whatever you're counting on for definitive control of ICP, you can use hyperventilation briefly in order to get the patient to the operating room, for example. This is the current list of recommendations. It's not in the handout. Somehow my 2000 slides were in there instead. This is the 2007 set of recommendations regarding hyperventilation. There's insufficient data to give a level run recommendation. You can see in the old ones it says that there's really not a standard. Level 2, now they say prophylactic hyperventilation is not recommended, and that really comes out of the Muselar study, which was not an attempt to lower ICP. It was prophylaxis versus not. And then they say a few other things in their options part, level 3. You can use it as a temporizing measure. You should try to avoid it in the first 24 hours. And if you use it, you ought to find some way to measure brain oxygenation in order to not do too much. All seem very reasonable, but as usual with level 3 recommendations, that's just what people think. This was the data that actually showed us that you should keep the CPP at 60. Before that, we were typically using 70. In this circumstance, they showed that there was no benefit to going to higher than 60. Just to look at craniectomy, you can see the degree of shift beforehand. After the craniectomy, the midline is moved back to the middle. There's better perfusion of the rest of the brain. Craniectomy has an increasing affection among all of us that do neurocritical care. These are the number of papers on craniectomy per year. You can see somewhere around 2,000 people got very interested in this. There are different ways of doing it. I won't trouble you with that right now. The other thing to keep in mind about craniectomy I mentioned in the stroke talk was that the patient who has a large, usually middle cerebral infarct, based on now 3 European studies, none of which went to conclusion because they were all stopped early for very marked efficacy, has not only a better survival, but a better functional outcome with an early craniectomy rather than doing whatever best medical management seemed to be. And you might say, well, gee, I would rather be dead than have this deficit. And that's certainly an opinion to respect. There are very few people who have talked about their experience in craniectomy, but there is a paper in neurocritical care by an anesthesiologist about 4 years ago talking about his life after his huge stroke and craniectomy. And in the paper, he publishes his post-op CT scan, and you'd look at that and you'd go, this guy could never do anything, but in fact he's writing papers with a little bit of assistance. But maybe you don't need much to write a paper, but nevertheless, your assumption of what somebody might want should be tempered by increasing amounts of knowledge about what the post-op outcome of these people is like. Obviously, you don't want to have any of this in the first place. If you have a stroke, you want to get adequate thrombolysis. But if you have a big infarct, the idea of doing a craniectomy, which used to be thought of as odd, and when I was in training, no one would ever think of it. It's better to let people die than to let them have a weak big finger. I'm going to skip over some of these. So this is one of those three studies called Hamlet. And in the Hamlet trial, there was a... All right, got 5 minutes left. In the Hamlet trial, you can see from the data here, they had to stop it early, as I've mentioned. There's one summary paper that talks about 3 trials together, and then this one. So that just keep this in mind. It's, I think, one of the bigger advances in what we're doing. We actually do a fair number of these now. There is a question as to what the upper limit in age ought to be. We know from craniectomy studies involving trauma patients that much over the age of 30, the trauma patients don't do nearly as well as the younger ones do with the craniectomy, which is, of course, true in general for the trauma population. The upper limit in these studies has pretty much been the age of 60. I think we should really be approaching it from the idea of the anatomy, that somebody who's got a tight brain and is likely to swell a lot, we're going to save them from going through herniation by doing the early craniectomy. So if we're going to do it, we want to do it early. And whether 60 ought to be a cutoff looks a lot more questionable as I get closer to being 60. So if the person's got a lot of atrophy, even if they swell, they're not going to have a lot of mass effect and shift, so that they might not benefit from the surgery. But if their brain is relatively tight to start with, that's the group that I would consider this in. And again, looking at this change in the Rankin scores, you can see that in the medical group, 19 patients were dead compared to 7. We typically use Rankin scores of 4 or better in these huge infarcts or in hemorrhages to say better outcomes. So this does involve some degree of disability, but you really have taken people who were going to die and moved them into reasonable outcome groups. A few words on fluid management. This comes from a trauma study. You wouldn't be surprised that having an ICP over 25 predicted a bad outcome, or that having a lower mean arterial pressure predicted a bad outcome. But interestingly, fluid balance plays in here. And in a in a multivariable analysis, in fact, fluid balance was one of the most important things. But it wasn't keep the patient dry the way we'd been taught. If patients got more than 600 mLs negative in the first 72 hours, that itself predicted a bad outcome. And it's one of the problems that led to this hypothermia trial, we think, not showing an effect on outcome, that the critical care management of the patients, other than their temperature, was so variable from one center to another, it became difficult to tease out anything, except that the patients who were allowed to get dry did badly. So, our next question here, let's see if people have been listening. Most effective technique for controlling elevated ICP is craniectomy, hyperventilation, high-dose barbiturates, mannitol, or hypertonic saline. So go ahead and vote. Great. All right. So there's no question that the craniectomy is the most effective way of doing it, but it doesn't mean that these other things are irrelevant. Again, hyperventilation to buy some time. High-dose barbiturates work by decreasing cerebral oxygen demand. So to the extent that there's still coupling between demand and flow, you'll decrease blood flow, but you're doing it in cells that are being made to have less demand, and therefore they don't become ischemic. You could just lower flow by lowering the blood pressure, but then you run the risk of producing ischemia. Now, what's the effect of giving high-dose barbiturates? A lot of what we used to look at was probably really related to the poikilothermia, which may be the most neuroprotective part of this, because these patients will tend to assume room temperature if you're not careful with them. And I'll talk a little bit about mannitol versus hypertonic saline here. So just a summary of the things as we get to the medicines. You want to avoid hypoxemia and hypotension, and those are the two things that occur even in really good intensive care units. They occur transiently, they get noticed, but they don't get managed fast enough, and it's pretty clear that each hit in either hypoxemia or hypotension worsens outcome in head trauma. Remember that about 20% of them will have serious cervical spine problems, so you don't want to irritate those worse. How should you intubate these people? We typically think that orotracheal intubation with inline stabilization is the way to go. Don't put any tubes in their nose for any reason. You don't want to publish the next picture of a tube that goes through the cribriform plate up into the brain. Should you do a fiber optic intubation? You should do whatever is fastest. So if you have a glide scope there, that's probably a great way to do it. But doing standard intubation is better than letting the patient get hypoxemic. Head posture turns out to be quite important. It does lower intracranial pressure, measuring it the way I've described, and CPP to have the head up at least 30 degrees. You can continue to get more effect by going higher until you get to the point where you've flexed and compressed the abdomen, and then you may start to see effects on intrathoracic pressure. Also, don't let the head turn side to side, even if the spine is fine. A little bit of jugular venous compression will result in a big spike in ICP. If you want to test this, next time you have somebody with an ICP monitor, just push on a jugular vein a little bit. You see the ICP go right back up. Of course, when you take your hand off, it'll go right back down, I promise. What should you do about intubating people? Give them something to blunt the ICP increase with intubation. Intravenous lidocaine does work. Local lidocaine in the neck or in the pharynx does not work in the larynx. But thiopental will work, etomidate will work. It's something that will blunt that increase. All right, how about osmotic treatment? Mannitol has a lot of potential mechanisms of action. It's a free radical scavenger. It improves red cell deformability, blah, blah, blah. All right, we don't know yet which of these is better. There are a couple of small comparative trials. The mannitol dose we give is usually much more than can actually have an effect. So the one study that looked at dose compared 0.25 to 0.5 grams per kilo, 0.25 worked as well but needed to be given a little more often. Hypertonic saline is the darling of all this. There's no question that you can occasionally rescue people who have failed mannitol with 30 mLs of 23% saline given through a central line. The question is, when you're starting these treatments, is one better than the other? And the answer at this point is really not known. The hypertonic saline effect appears to last longer between doses. We do know that. Don't let them get volume depleted. Sedation to decrease cerebral oxygen demand is useful. People often overlook analgesia. If you're using propofol for sedation, you're not giving an analgesic agent. So keep something in the back of your mind for that. This is actually a good use for ketamine to function both as an analgesic and as a sedative. And if you're controlling ventilation, you don't see an increase in intracranial pressure from ketamine. That was a mistake in older literature based on a slight amount of CO2 retention causing some increase in cerebral blood flow. This is one of the papers that compares mannitol to hypertonic saline. Maybe it helps more. Hypertonic saline here shown to decrease or to reverse herniation once it's already occurred, something we think of as difficult to do. And I'll skip over that because I'm about out of time. You can look at these at your leisure. Ventilatory management I've already mentioned. Modest hypocapnia has been chosen because that's what patients do if you leave them to themselves. If you're going to intubate them, use a non-depolarizing agent, especially if their ICP is a problem. You can gain a couple of millimeters of drop in ICP by giving a neuromuscular junction blocker. It's never been quite sure to me how this works. I think you're actually decreasing intrathoracic intra-abdominal pressure, so you're improving jugular venous return, but that's a hypothesis. CSF drainage can be quite helpful. Barbiturates when you're at the end of the line, and we've talked about these points, except should you do hypothermia? I'd say at this point, the rest of the world does hypothermia for adults with head trauma. Unfortunately, Guy Clifton's studies had problems that have not yet been resolved. And say that it's not the standard of care to use hypothermia except when you have intractable ICP problems, because it does lower ICP. A European study that's getting started this fall is going to compare the use of hypothermia strictly for ICP management to other modes of ICP management to see whether it's more efficacious or not. In children, it seems pretty clear in all studies now that hypothermia does not improve outcome after head injury. Should you give anticonvulsants? The standard has been to give phenytoin for a week. This doesn't affect long-term epilepsy, but it does decrease the acute seizures that can occur. Whether the newer drugs are better, nobody knows. Attempts to use valproate were stopped because there seemed to be increased mortality with the valproate. Feed them, give them GI prophylaxis as long as they're on a ventilator. You can go ahead and start both boots and sub-Q heparin, and that's the end of that. Thank you.